This is going to be a highlight of your day because I don't know about you, but I kind of geek out when I see a lot of the new models coming out. And for years, there always is, it's like the weather. Is it going to be hot? Is it going to be cold? And there was a lot of uncertainty what was going to happen. What was going to happen with value care delivery? What was going to happen with were there going to be new models? And you know, the holidays came early for us, and we have a whole host of new models, and we absolutely have a star-studded panel now. The reason why I'm excited about this panel is because we have the national experts and the real world, here's what we're doing about it. So this is going to be a combination of what are you seeing conceptually as well as the reality. So this is going to be fantastic. Now, before I introduce the panelists, as part of this, I like to share anecdotes. Why? Because we're also real people, and it gives you something fun to talk about at breaks. And also, if you want to know everyone's professional accomplishments, we all look on LinkedIn. But the things you can't find on LinkedIn, Aisha Pittman, who's the SVP of Government Affairs for NAACOS, she is a skier, hasn't skied in a while. She came to us straight from skiing, and the good news is we don't see anything broken, all together in one piece. So glad that you could join us.
I made it, but my body is incredibly sore after having years off. But yeah, so happy to be here. Thanks for having me.
Really appreciate you being here, Aisha. And then Sam Hiatt. Sam, the thing about Sam, how many of you like to go to the gym? A show of hands.
Oh, I got some.
How many of you are power lifters? Anyone? No one. Well, we were hoping, so Sam is actually doing his first powerlifting competition. We were hoping that we were going to find someone in the room that could give him some tips because he's looking forward to it.
Every tip I can get. This is my first one, and very nervous, primarily focused on not injuring myself at the moment. But do not give in to peer pressure is the end goal here.
That's right.
Yes.
That's right.
I like it. Well, all the gym people will still talk to you at the break about that. And Lisa alluded to this in her last panel, but Lisa actually grew up off the grid. So it didn't mean that she didn't have electricity. They had the solar and the batteries, but they were not connected to anything for essentially her entire childhood. Yes. So that's a pretty unique experience.
A real rural Northern California childhood, so to speak.
Absolutely. So now that we have interesting things to talk about at the break, let's turn to our regularly scheduled program and let's talk about what's really going on. So we know that we have REACH that's going to end at the end of this year. We've got CMS introduced a whole host of new panels of different new programs for us. And Aisha, I know you're the person who's kind of in DC watching this. Give us a rundown of the new programs and like what's the DC inside view on them?
Yeah, there is right now a lot of excitement but also caution. So across the slew of announcements of new models that we had at the end of the year, I think what we hear from our members are excitement about the future. So another commitment to accountable care with the LEAD model, focus on tech-enabling healthcare with access, and then addressing pharmacy costs with a slew of models. And I think it's excitement because the top line of what we see in these models is a lot of things that providers have long wanted, but caution because we don't have the full details yet.
Yeah, and along those lines, and this is common when CMS has their new models, real big splash, gets everybody excited, and then all of a sudden, you know, there's that webinar they have where it goes through, well, here's actually what the payment's going to be. Here's how we're going to set the benchmark. So what are you anticipating are going to be some of the, perhaps, you know, Easter eggs that are there, as well as some of the gotchas?
The Easter egg and the gotcha for LEAD will be around benchmarks. That is your essential budget, how you're going to manage costs in the model, and you know, there have been challenges in REACH right now. A lot of our members are struggling with the retrospective trend adjustments that are arbitrarily lowering benchmarks. So we're trying to look to see how CMS is going to solve that long term. We're also at a point in the history of accountable care where providers have been in this for so long, and as you all know, when you recontract, you're rebased, your benchmark is lowered, and whether you have been in REACH, MSSP, no matter what, going into a new model, you're going to have this benchmark ratchet. So we're looking at how CMS is starting to solve that long-term problem, because we need to address that long-term problem to sustain accountable care. But then there were a lot of other Easter eggs that are really positive. So addressing small, independent rural practices, having better benchmarks for high needs and complex patients, integrating Medicaid in part of the model, eventually moving to drug Part D cost sharing reductions for beneficiaries. So there's a lot of good nuggets there, but still need details.
Absolutely. And Sam, you're in this interesting position where the details aren't there. You're in charge of operations. Yes. And so it's like, this is the reality of your organization is sitting there saying, okay, we need to look at these and tell us a little bit about, as you looked at the new programs, what did you see as the pros and cons, and what are your current thinking on them?
Yeah, so there's a lot of excitement about this. There's, a continued shift towards value-based payment models, and really we feel like we're well positioned and partner with primary care across the state to facilitate these models for them. So when we think about access, we see a lot of benefit, but we also see a lot of risk for our practices, specifically around fragmentation of care that could be inherent with access. So, this opens the door for direct-to-consumer outreach and enrollment of patients and really cutting the primary care provider out. So right now we're really focused on how do we build a moat around our primary care as the focal point of the holistic patient experience, and making sure that they are still the medical decision maker on the team and they're not being cut out of that process. So we feel like that's really important for us to be at the table and be there early so we can support our providers and our practices with that, but also provide them an opportunity for making sure they're continuing to be sustainable. We have a lot of talk about rural health transformation. North Carolina is a very rural state, and so how do we make sure there's continued access to care through these value-based payment models, making sure that they're successful in them, and providing resources to them to enable them for success. So we think with access, of course, there's a significant tech approach. How to utilize tech to really extend your care team and engaging patients asynchronously. How do you create a surveillance system so that you can identify patients coming out of range? So a lot of time right now is being spent on how do we operationalize that, how do we build that out, how do we integrate that into our current platform and our tech stack, but also how do we integrate clinically with our internal care teams and our provider teams to make sure these patients are supported and clinically moving in the right direction. Because at the end of the day, the payment is entirely based on the outcome. It doesn't matter really how you get there, but you have to achieve that clinical endpoint for the patient. So how do we make sure we're set up for success for that? Around LEAD, I think, there's more outstanding questions on LEAD, I will say, benchmarking being one of the key concerns there, but hopefully moving in the right direction with some of the structural changes, getting more involvement into risk-based arrangements, hopefully getting more provider engagement with that. And I think as we move in this direction, it's not going to be an if you're involved, it's going to be a when you're involved. And so how do we prepare our practices and our providers for that eventuality so they're set up for success for these risk-based models, starting with LEAD and other models to come.
Yeah.
So one thing that's interesting is I heard you sharing how you're approaching access. It sounds like you're looking at this, there's almost a defensive component to
Absolutely.
this. So share a little bit more about that. When you look at the landscape, what do you see happening, and who are you defending against?
Yeah, so there's a lot of interest in access. You go to Substack, LinkedIn.
Lots of LinkedIn posts.
A ton of LinkedIn posts. You hear all sorts of information and misinformation around access. But when we look at technology companies, we look at virtual clinics, we look at these organizations that are really wanting to break into this space and leverage the technology component to engage patients, enroll patients, and potentially, pull patients away from their PCP and their primary care focal point. That's where we see the risk coming in. And it does not have to be a referral process to enroll in the program. There's direct-to-consumer outreach that can occur. We know these tech companies are very sophisticated when it comes to marketing and patient engagement and how they really get patients enroll into the model. So if it's a provider-led model that's prescribing or modifying therapies, there's only a requirement to inform the PCP. So they're not consulted, they're not engaged, and they are really responsible for that holistic view, whereas the access participant is really hyper-focused on these chronic conditions that they're managing. So how do we defend against that? How do we really be first to the table to say to our patients and our practices, hey, we are your access partner. We want you in our program so we can continue to provide that care and continue to move you on this path to success. And we're going to give you some more tools to get there. We're going to give you wearables, or we're going to give you enhanced outreaches. We're going to give you more regular touch points. So really enhance their care while also building that moat from others that are looking to break into that.
I think Access was a great example of the cautious optimism. So when it was first announced, I think a lot of our members were very interested in going into the model. And then once we saw the details and seeing that you cannot bill fee-for-service Medicare and be an Access participant, that takes most provider organizations out of the mix completely for being the applicant. Now, of course, the provider organizations are working and partnering with the tech companies, but I think Sam perfectly highlighted so many of the challenges that we're hearing from our members about that defensive strategy. And we've been engaged with CMS of how can you support with that defensive strategy. So it's great that they're required to notify the PCP. Well, we also think you should be required to notify the Accountable Care Organization for beneficiaries that are aligned to ACOs, because they're supporting the PCPs with management. And instead of just a notification, there should be some requirement around communication landed, because everyone's inundated with so much data. And so we're just worried that it's going to be create beneficiary confusion and be almost too much care management. And so I think many of our members are thinking similarly of how do we support our beneficiaries with knowing about all of the direct and interpreting all of the direct to consumer marketing that's coming to them. I think for us, it's also a signal of, we've been asking CMS from accountable care perspective to be able to better communicate with beneficiaries and to market directly to beneficiaries. And so we are taking this example of saying, well, if you're allowing tech companies to do this, we're responsible for total cost of care. Let us be able to directly outreach to beneficiaries in our markets to bring more beneficiaries into ACOs. And we know that CMS has that goal of getting more beneficiaries in.
Now, Lisa,
Yeah,
I hear you work for a tech company.
I work for a tech company.
And I hear that a lot of the
I also used to
customers-
write models at CMMI.
Right. And a lot of the customers at the tech company
Yeah.
are looking at this. So tell me, how are you looking at this?
Yeah, so it is true that Abhinav is my boss, but I also used to work for CMMI and know the many trade-offs involved in writing and planning these models. There's a really good policy idea here, which is that, you know, other people who aren't traditional Medicare beneficiaries have been able to access some of these, these innovative tools, tech forward, care coordination, musculoskeletal, many people have heard of, Hinge Health, Sword, et cetera. And that's not as accessible or available to Medicare beneficiaries in traditional Medicare, with the exception that ACOs have been thinking about how to incorporate technology in these tools for a long time. So there's some really good proposals that we would generally support that, NAACOS has put forward here. I think one thing really important to know, as always, not all the information is available yet, of course, as we said here. It's our understanding, and we could be wrong, that the access model, it's paying on outcomes, paying on specific health outcomes for each of the areas it's covering. It's our understanding that payment amount, if you achieve those outcomes, is not really going to support human-led in-person care, whatever it is, even care, by remote RPM. It's going to be a number that is going to require a technology-first approach, and that will challenge all of us a lot. So I think there's one area there. For myself from the tech company, please understand I've got to put this in here. Innovaccer is going to be supporting, hopefully, our customers, our partners on this, because we can actually do that technology piece, and we can also even cover the carve-out billing piece if necessary to make it possible for you to continue to provide care, and then also hopefully close those loops. We would support that communication back to the ACO, communication and engagement with the PCP. We're hearing now, as we talk to folks who are considering, what do we do here? How does this work? That's what's going to be needed so that access beneficiaries, patients who would be receiving care otherwise in your system, let's say, don't get lost to follow up, lost with some totally unrelated tech solution who doesn't communicate back to you. So we're hoping to fill the gap that each of you are illustrating here. Again, early days, lots to learn, but that's how we're thinking about it when we think about the challenges that health systems generally and the delivery system will be facing with these new models and that new approach.
Fantastic. Now, staying on the theme, but go in a slightly different angle, Sam, I know one of the things that you're looking at is primary care and specialty care coordination.
Yes.
And that, you're like, that's it. And obviously it's a big issue. So give us some nuggets there. Tell us what you're doing on a very specific basis as you're thinking about some of the new models and that.
Well, first off, early days on this. So, one key component is, high value, especially referrals and steerage. And so how can we partner with our payer partners to identify those in-network high value providers across the state? Of course, there's going to be regional variations, et cetera, that you have to navigate through. But how do we utilize that data to then feed that data back to our providers when they're making a selection for a specialty referral or for an imaging referral, and make it seamless and effective? Because we know these providers are very busy. They're not going to search through a database. They just need to know, okay, who do I need to send this?
The fax machine is out of
toner. The fax machine is out of toner, and we cannot get that fax out. So how do we quickly and seamlessly direct them and really driving down the overall cost of care and controlling the overall cost of care? Again, we talk about the ACO risk here. That's a key component of it is, and with LEAD, with the CARA component of that, perhaps building some specialty arrangements with shared risk taking with these groups. And so how do you really facilitate that, but also shepherd your providers to be referring to these high value sites of care? So ongoing process, we're looking to utilize Innovaccer and our partnership there to help manage that and facilitate that, but really get it right there front and center in front of the provider, so it's not an abrasion point. It's really an enhancement to their daily workflow and practice.
Fantastic. And Aisha, obviously, NAACOS members, this is a big thing, specialty, primary care. Also, let's throw in the mix here, there's some mandatory models. So maybe if you want to share a little bit, what are you hearing from the membership base regarding first of all, the primary care, specialty care component with LEAD, as well as sprinkle in the mandatories?
Yeah, I think within LEAD, there is excitement about still having capitation options, being able to go towards full capitation. What our members really want to do is get away from reliance on the CPT codebook and to design specialty and other types of financial incentives for providers that they see fit, and aligning those incentives and reimbursement methods with what they're doing in risk-based arrangements with MA and Medicaid, so aligning across all populations. So with the CMS administered risk arrangements, this concept of nesting bundles within the ACO is something we have been talking about for what feels like decades, since the BPCI first version of the bundled payment models was out, because there was always this challenge of model overlap, and when your beneficiaries are in a bundle and the ACO, who's on first, how is that coordination happening? And it just always felt like these things were happening in isolation. And so to do it specifically within the ACO is forcing the coordination and leading it from primary care, with primary care at the centerpiece and coordinating with specialists. So we've been saying to CMS for a while, we need enhanced data. And so, this CMS risk administered piece seems to be giving us the tools that we need to get there. So I think there's some excitement about that. I think the concern comes into all of the other mandatory specialty models that are on the table. So with TEAM, which is led by the hospitals, and with ASM, which now goes down to the individual provider, it's not even at the provider group. There's just a lot of uncertainty, particularly in the markets where all three models could be operating, how you're just going to coordinate and manage to all of the varying requirements. And so with TEAM underway and more information coming on ASM, it's just how you make everything work within total cost of care.
And also what your mix is, what your population mix is. It's going to really change, obviously, how much you care about any of these things, right? Maybe, you have such a small mix that one of the models is such a small part of your business that you're like, we can't even, we'll do whatever, we can't deal with it, it's not part of a priority. Others will be like, this is existential for us if we don't get this right. And that's really challenging. I think the multi-payer and the population mix question has always been a real challenge for CMS and for CMMI. CMS being, so fundamental in driving the direction of healthcare policy, how we think about risk, how we think about, engaging different populations. But it's just different for every entity who's involved in some way in this, accountable care or value-based care or population risk perspective. So it's hard to make one statement about what's going to matter to you.
Yeah, I think we're also seeing lessons learned from the CMS perspective. There was previously a focus of having true multi-payer models, and they were always a struggle because you could not get payers to the table. And I know what we shared that our members wanted to see was more flexibility in the Medicare model so that you can align it with what you're already doing. And so I think LEAD signals that they have heard us and are giving us the tools to align rather than trying to have a multi-payer model.
Yeah.
Fantastic. Now, before we continue on our conversation, a quick commercial break. We have a survey, so feel free to pull out your devices and scan the QR code. And the survey is specific to the models. So what we're trying to do here is let's get all of your opinions and perspectives, and then we're going to take this information from the survey, compile it, and it will be included in either an article or something post-conference, so you'll be able to get a greater sense of what everyone in the room here is thinking at some point in the future.
Yeah, we really want to know what you're thinking about, what you're concerned about, if you're going to be part of these models, if not. It's really important to help us. One of my own commercial break here is that another part of my job, of course, is to take what we hear from our customers and our partners and go back, just like Aisha does, to CMS, to HHS, and give that feedback and say, here's what we're hearing from folks who are actually implementing this work.
Okay. Back to our regularly scheduled program now. We saved the best for last, behavioral health. It never ceases to amaze me how much of an impact behavioral health has on all aspects of care. And at the same time, we really don't have a lot of good systems, processes, and programs set up to address it. I know, Sam, that's kind of top of mind for you, especially for your population. Would love for you to share how your organization's thinking about this.
Yeah, so North Carolina has a COCM model that we certainly partner with providers and practices across the state, as well as other organizations, to help facilitate that and get behavioral health specialties in the primary care setting. So how do you, again, enhance and extend those resources from the primary care to these specialty conditions and hopefully improve this? Again, I'm so focused on the Medicare population, that's what I'm always thinking about, but it's such an impact in the Medicare space. And so really, again, partnering with practices, making sure they have access to this care is always the challenge. Also, how do you get reimbursed for this care? So how do you pay for it? That's always going to be, if you talk to your CFO, how are you going to pay for this service? How are you going to pay for this provider to work with our patients and our practices, because we know it is critical to the overall health of that patient. And so North Carolina has definitely made significant enhancements to that and big strides in making sure that is available and accessible to our patient population across the board through our different Medicaid products and care management products. And then, we partner internally with our care management teams to identify and then route patients to these behavioral health providers. So hopefully kind of an early warning system to identify these patients early on, and so we can engage them rapidly, get them the care that they need, and hopefully prevent a further escalation of that condition.
Just really quickly, I think in the behavioral health space broadly on the policy side, those of you who have your ear to the ground probably saw that there's those 24 hours where all of the SAMHSA grants were cut, and then they were brought back. They were brought back because a number of advocates worked like 24 hours a day to make it happen very quickly and point out, how foolhardy that was, and we're in the middle of a behavioral health, substance abuse crisis, like very important thing that happened in the policy space here. I think for other stuff that we do, data privacy remains huge challenges that we haven't totally overcome yet. And then also looking across state budgets and also everyone else, just general operations, we have an issue that is really coming to a head. We could bring those boxing gloves back up here around coverage and parity. Of course, since the Parity Act was passed, there is truly a battle on reimbursement and making things available. The behavioral health workforce is different than other parts of the healthcare workforce, and so there are a bunch of challenges there. A really big issue, a lot going on. This will definitely come up and complicate, the way that we can look at the overall health outcomes picture. We will say, part of access, there is a behavioral health option. I'm very interested to see how that plays out.
And just to add in an additional component, one thing I always encourage clients to look at is ACEs, Adverse Childhood Experiences. And so this is 10-question, yes, no, and the CDC, I see some nodding in the room, the CDC covers this. It really is probably one of the most predictive factors for future adult illness. It's very controversial, it's very personal to discuss a lot of these things, but the value of that survey is incredible. So Aisha, going to give you the last word here first, and then we'll let everyone else after you give a quick, 60-second, what is your most important take-home message? What do you want people to walk away thinking about?
I think most important message is strategy. I like the popcorn, not partnership, not popcorn. So
partner, not popcorn.
Yeah. How are you partnering across all of these things? So while I think I seemed very guarded about access, it is a huge opportunity to really think about how we shift payment for care and how we pay for things that have not been traditionally covered by Medicare. And that does, even though providers can't directly participate, it does open up huge partnerships. And then the LEAD model is really forcing you to think about how you partner across the continuum of care and how you leverage payment to engage in those partnerships. So I'm gonna sort of double click on the partner, not popcorn.
Love it. Sam?
I think for me, the biggest focus for us is the continued shift towards value-based payments and making sure that you are prepared for that, the focus on chronic condition management, and really utilizing tech to enhance your ability to engage your patient population outside the brick and mortar setting. I think that's going to continue to become more and more important to really, truly manage it at a population level. And so just making sure you are ready for that transformation because it is coming.
Yeah. And I would just say you cannot be successful in these future models if you aren't willing to go through that deep workflow redesign. You won't be able to make money or not completely lose your shirt on all of these models if you haven't gotten rid of those fax workflows around referrals, for example. If you haven't really thought about what does this look like. I cannot emphasize that enough. This is a time that really demands that we make those data connections, achieve the interoperability we need to provide the data for these models. That's really, really important. So workflow redesign is a must to be successful and should be part of your strategy, whatever it is, whichever models, whichever programs, whichever initiatives you're part of.
Fantastic. So let's give the panelists a round of applause. Thank you so much.